welcome everyone to the last DCR Journal Club for the year. We've had a number of them. I think we've had 10 for the year. I mean, I'm obviously very biased, but I'm very proud of what we managed to do in our program, and I'm very grateful for all the host institutions and the special guests. Now, we will be sending out a survey to get the coveted top 3 special guests, and we're going to promote them on Twitter. You're probably not going to get a trophy, but I think it's the thought that counts. So thank you all. Next slide, please. Our team, and next slide, please, and our disclaimers the same. And next slide. And so today we're in Ann Arbor in Michigan. I've already mentioned, I guess I have to congratulate the Wolverines for beating Ohio State. Not being a football fan myself, but I understand that this is a major thing. The fun facts I've found about Ann Arbor was, one, it's the home to the Fraggle, which is a hybrid bagel donut, as far as I understand, which is kind of like a mule, being a half horse, half donkey. But the more interesting thing from a surgical point of view, it's the home to William Bovey, the inventor of the diathermy pencil, and it might be common news knowledge in America, but certainly I mention it to all the residents in Australia that the colors on the diathermy, as we call it, is the University of Michigan colors, which I think is remarkable. But from now on, I'll get Dr. Byrne to introduce his city and the faculty and the university.
Thanks so much for having us. We have a couple pictures there. That was the Huron River in downtown Ann Arbor. The big house is the nickname of the football stadium, which I think holds 122,000 fans. And on this Saturday, also got 6 inches of snow and a victory over Ohio State. That's our somewhat sprawling hospital complex. And the University of Michigan Medical Center is famous to me when I came here in 2015, because when they glove you in the operating room, they glove your left hand first instead of your right hand. I don't know of anybody else that does that.
I actually insist on it. I like it personally, and I don't.
We're hiring. I mean, we're hiring.
Yeah, I'm there.
What's the next slide? I think, okay, so really appreciate our fellow, which is Sarah Diaz, Dr. Diaz, who we have a shared fellowship with St. Joe's and Ann Arbor. She will be taking a job in slightly northern Michigan next year, and is our fellow this month and 2 months coming in the spring. And then Dr. Alicia Lucis is in her research time and interested in colorectal, probably applying in about 2 years. Dr. Quachi is my partner and will be one of the discussants, as is Dr. Regan Bogan. And I'm John Byrne.
Thank you for that. So the next slide is the poll that we usually do. The question for the poll is as written there, just to get people's feel on what their fluid management is for patients with an ileus. We're going to leave the poll up there. Please fill it out when you're ready, and we're going to move to the next slide now and start our first article. The article is a systematic review and meta-analysis of NSAIDS to improve GI recovery. With the authors as stated. The first author, Stephen Chapman, is kind enough to join us, so thank you very much for that. It's fantastic to have authors at the Journal Club. I think it's very unique. And the article is presented by Dr. Diaz, and then the moderating faculty member is Dr. Regan Bogan. I hope I pronounced that correctly.
Awesome. Can you guys hear me okay?
Yep.
Okay, perfect. So next slide, please. Great. So data shows that between 10 to 20% of patients undergoing colorectal surgery will develop an ileus. Recent evidence suggests intestinal inflammation and neurogenic dysfunction may play a key role in development of said ileus. NSAIDs after colorectal surgery may accelerate return of bowel function by inhibiting synthesis of prostaglandins and reducing neuromuscular dysfunction. There is concern regarding the relationship between NSAIDs and AKI, as well as some research suggesting an increase in anastomotic leak. The objective of this paper was to explore the safety and efficacy of NSAIDs to improve GI recovery after colorectal surgery. Next slide, please. So this was a systematic review of current literature through January of 2018, looking at randomized controlled trials, assessing the effects of NSAIDs on GI recovery after specifically colorectal surgery. All eligible studies analyzed looked at effects of NSAIDs, either COX-1 or COX-2 selectivity, on GI recovery or length of stay as the primary outcome in patients 18 or older undergoing colorectal surgery. The primary outcome of the particular study was GI recovery, including but not limited to time until first flatus, stool, and tolerance to PO intake. The secondary outcomes included morphine consumption and incidence of post-op complications. Next slide. So 6 randomized controlled trials met the inclusion criteria, and this involved data from 563 patients. Most were single center, involved both colon and rectal surgery, and used an open approach as a surgical method. 4 of the studies tested non-selective NSAIDs, most commonly ketorolac. 1 study tested a COX-2 selective NSAID, and 1 study tested both. In most studies, patients received NSAIDs in addition to a morphine PCA. So what they found was passage of flatus and stool was faster in patients receiving NSAIDs. This was reported in 5 out of the 6 studies. The time to tolerate PO intake was faster in patients receiving NSAIDs as well, reported in 3 out of 6 studies. And morphine consumption was lower in patients receiving NSAIDs in 4 out of 6 studies. 1 study showed no difference in morphine consumption in the NSAID population. However, patients still had faster return of bowel function when NSAIDs were used. Another study demonstrated no correlation between improved GI recovery and reduced morphine consumption. So there were no significant differences in the incidence of postoperative complications between NSAID and control groups in any of the studies. However, one of the studies was halted temporarily due to an increase in anastomotic leak. It was 4 patients versus 1 patient, and the study was resumed, and they sort of determined that this was an anomalous observation and not an actually statistically significant finding. Next slide. So limitations of the study: the majority of the data collected was from randomized controlled trials published between 2005 and 2009, so relatively old data. The majority of the operations were also performed open. And one of the NSAIDs that was used in the study was actually pulled off the market after the fact due to its known concern for cardiovascular adverse effects. So ultimately, the authors concluded that the review was unable to offer a definitive answer on the role of NSAIDs in GI recovery. However, I believe this paper highlights the deficiency in the literature and an opportunity for future research.
Thanks very much. That's a great summary. Might move on to Scott. If you can, just tell us what your take-home messages from this study were.
Sure. Yeah, thanks for the invitation, and nice job, Sarah. I mean, I think, whenever I read meta-analyses, the first question I ask myself is, why do I think the authors did a meta-analysis here? So is the issue that there are conflicting studies and they're trying to resolve them? Is the issue that there were several studies that were underpowered and they're attempting to accrue enough power to create better conclusions, or is there some sort of just lack of consensus and a need for pooling? And here, it's a little of both. I mean, on the one hand, this is effectively the same conclusion from most of those studies, but there was this other question of adverse events. And so the question is, did it really add to that one? And when I read a paper like this, I have massive bias here. So I once had to give a talk about analgesia at some meeting, I don't remember which one. And when I got to NSAIDs, the slide that I had was just a picture of an ostrich with its head in the ground, because I just don't want to hear it because I so believe this is an important part of our perioperative care protocols that if it increases anastomotic leak, it's going to destroy me. So I have absolutely no equipoise here. In Michigan, we actually, because of a very strong effort at opioid reduction, we actually have a program with our largest commercial payer, Blue Cross Blue Shield of Michigan, where if we enroll patients in a comprehensive program that involves counseling and perioperative care protocols to reduce opioid consumption, we can actually accrue RVU-related bonuses from Blue Cross for getting the patients through that system. And that protocol involves NSAIDs as well, in order to reduce opioids and reduce opioid prescribing after surgery. So when I look at this paper, the first question I ask myself is it important? The thesis in the paper is that there's lots of hesitancy among surgeons. So I guess the first question is that true? I was wondering whether your poll was going to be about, do surgeons use NSAIDs? Because certainly where we are, there's very little hesitancy. Now, I mean, I've read Tarek Samwar's piece that basically said, hey, maybe we should all stop giving NSAIDs until we resolve this question. But again, I just chose not to read his piece because I didn't want to hear it. So the first question is like, is there really hesitancy or not? I'm not clear that there is, certainly not around us, but there may be in other parts of the country, other parts of the world. The second is it important to me to create a meta-analysis of studies that are 10 to 15 years old, largely predate the laparoscopic era, that are largely from other health systems other than mine, and a couple of which don't use the drugs that we currently use. So to me, I don't know exactly what to do with those findings. And there's a statement in the paper about, that we don't see on the horizon new studies coming. And I kind of wonder whether that's part of the reason why. The second question I ask myself is, are their findings valid? So the first question is power. As far as the adverse event data, there probably aren't enough power, even in this whole put together meta-analysis, to really make valid conclusions about anastomotic leak. Again, much to my relief. And the second is reproducibility. So, why do the findings from this meta-analysis differ from the two other systematic review and meta-analyses, one of which was published in DC&R that concluded that there was a higher risk of anastomotic leak? Now, some of those trials included non-randomized controlled trials. They included observational studies as well. So that may be the answer, but it also raises questions when there are conflicting results from multiple meta-analyses. Third question is, what about bleeding? I worry about bleeding with NSAIDs, and that was not addressed here in this paper. And finally, the question of inclusion criteria. So, one of the real issues with most of our research in surgery has to do with selection bias in both directions. On the one hand, there's the selection bias of observational studies where, if you just do observational data, the patients we choose to give NSAIDs may be the ones who are less at risk of having complications of NSAIDs because we're pretty smart. If you do randomized trials, the patients you enroll in randomized trials may not be representative of all the patients that we will later operate on. I would bet that my 82-year-old with a creatinine of 1.6 probably wasn't enrolled in these trials. And so the question is, to whom can we apply this? And in those sorts of scenarios, we get interested in other methods of causal inference, like that we can talk about in other environments about how to deal with selection bias. So those are all the questions that come to mind when I read a meta-analysis like this. In the end, I think it's effectively well conducted. The studies are well chosen. They focus on randomized controlled trials only. I get to the end of the trial and it has exactly the conclusion I want to see, and so I'm happy with it. But that doesn't necessarily mean that I truly believe that it's the most valid interpretation of the real world data outside of randomized trials, which is really what we want to know about.
Oh, thank you so much. That's a fantastic breakdown, and I share a lot of your views. One of the things that is my cognitive limitation is understanding inflammatory cascades. And so I was motivated to use NSAIDs because I want to avoid opiates. When they start saying that somehow the inflammatory cascade treats the ileus itself, I genuinely, I just don't understand. And I often wonder, how does aspirin work? And we seem to, at least I don't ever care about having patients on aspirin. In fact, I think I just operate on them, but does that, hypothetically, would that affect anastomotic leak? Anyway, but back to sort of questions for you guys as the host institution. Now, you've mentioned that you have a stringent analgesia protocol. What is it? What is your algorithm for, say, a laparoscopic anterior resection?
I guess maybe unfair to make Sarah answer that because she's only been with us for a couple of weeks, but it's pretty straightforward, which is basically all patients get Tylenol both preoperatively and postoperatively. We give it orally unless the patient for some reason can't take a pill. They get unless they have a contraindication of some kind, which would be like need for systemic anticoagulation or renal insufficiency, they get IV ketorolac until they can tolerate oral pills within 24 hours or so, at which point they get oral ibuprofen. We usually let them have a patient-controlled anesthesia with morphine overnight. We take that away first thing in the morning, and then they use oral narcotics only as needed. Basically, we just tell them not to press the button if they don't need to. We used to give gabapentinoids. We were using gabapentin, and our anesthesiologist showed us some reasonably good evidence that that was associated with unnecessary sedation and mental status changes, especially in older adults, and really no actual evidence that it was doing much in the way of analgesia. We have not in our institution used IV lidocaine, or we have not in our institution used spinal analgesia. We will use epidural anesthesia for bigger open operations when we do them, usually not for laparoscopic operations. And I personally do laparoscopic guided transversus abdominis plane blocks with just with bupivacaine for my laparoscopic operations. I don't think all of my partners do that.
Thank you. Now, the other question, and again, I'll direct it to Dr. Byrne and he can distribute it. NSAIDS and acute kidney injury. What's a practical recommendation for people that, will be inspired by this journal club to start using it? Like, is it creatinine that you look for? Is there an arbitrary number? Like, when people have a bit of renal impairment, what do you do?
I'll answer and then have Dr. Quachi back me up. I think it's a combination of age and creatinine. I think if someone's over age 65 and their creatinine is above normal, that is cause for pause with using Toradol. Dr. Quachi, do you have a set rule?
I actually don't have a set rule. I follow a similar principle as you outlined, Dr. Byrne. I think it all depends. It's an individual basis and then what their statin creatinine is. We do know older folks are going to have a little bit more sensitivity, but I found some older folks who have great kidney function and have no issues at all getting some NSAIDs. So I think it's a case-by-case basis.
Thank you. My last question, and anyone in the audience, if they want to put some more things up on the chat, that would be great. But my last question or an observation is about sort of ruling in an anastomotic leak associated with a medication is incredibly then difficult to rule out, because I mean, we don't even agree on the definition of an anastomotic leak, let alone the variables that can affect it. But I guess if you were concerned about using NSAIDs, what would be a trial that you could design to reassure yourself or prove that NSAIDs are truly affecting anastomotic leaks? Because I think that's probably the thing that discourages people the most.
I have no idea how the trial would be designed, because I think the numbers would be so low that I think it would be prohibitive in time, and other factors would impact it. I think much more diagnosis, IBD versus cancer and things of that nature. Scott, how would you have some answer on how that trial would be designed?
Yeah, I mean, the randomized trial is probably impossible for two reasons. Number one is the numbers, and second is the people like me who don't want to enroll their patients in a trial where they don't get NSAIDs. This is one of those problems where the protocol violations would be horrendous because everybody has such preset biases. But I think I sort of teased that there are methods of causal inference that you can apply to these kind of questions. I mean, one, you can exploit the fact that there are real non-scientific biases among surgeons about this question to study it. So if you got a bunch of surgeons like me who give NSAIDs and ignore the potentially scary data, and a bunch of surgeons like Tarek Samor, who, based on his commentary, if I believe it, doesn't give NSAIDs because he's afraid of them, you can study it if you assume that my practice is not that different from his, and try to do a reasonable study of NSAIDs based purely on the attributed likelihood of receiving NSAIDs based on your treating surgeon. That's called an instrumental variable, and that's the way we've at the University of Michigan have used instrumental variable approaches to study a variety of surgical techniques and other questions that really can't be studied well in randomized trials. You could do it. I suspect what would happen if you really tried is you'd end up with no good answer, and we'd be right back where we are right now.
Thank you. I think maybe that's a reason why NSQIP keeps getting funding or something like that. Okay, there's a comment from Dr. Gottsman, I think, which is quite interesting in the chat about sort of the inflammatory phase, which I guess is a response to my question. Thank you for that. But in the interest of time, I'm going to ask I'm sorry, name escapes me, Dr. Chapman from Leeds. I don't know what time of day it is there, but thank you very much for joining us. And if you can tell us a little bit about, I guess you're the first author on the previous paper, but also about this thing that you're doing now.
Yeah, pleasure. And thank you, Vlad, and thanks to the editorial team for inviting me today. And Scott and Sarah, thank you for kindly summarising and commenting on our paper. It's an interesting one, isn't it? I completely agree with Scott in the sense that if we did a trial, even if it was a huge trial, powered for safety, which is a questionable aim, I think, even if we showed, even with an equivalence trial, that there was no difference in leaks, would people really listen? I suppose, do people just have their own opinion, and that's pretty difficult to change? So I don't know. I'm not sure if a trial is the right thing in the future, but maybe it is, maybe it isn't. But one thing we're doing at the moment, I suppose, following on from this systematic review, is this study here called the Relay study. So re-implementing non-steroidal anti-inflammatory drugs after bowel surgery. In the discussion of the systematic review we published, we set out a series of potential steps in which we could try explore this a little bit further. And one of those steps was a large observational study where we could look at safety, so AKI and leaks. And of course, that's going to be limited by selection bias. Another thing we considered was whether we could do some kind of scoping exercise to, I suppose, quantify people's perspectives and opinions of NSAIDs, and to try explore their position of equipoise. And this is what we're trying to do here. So this is, I suppose, it's a mixed method study. It has 3 steps, which you can see here, and I'll go through them very briefly. The first step, we're trying to get an idea of people's perspectives, a wide variety of people, so surgeons like ourselves, but also anaesthetists, nurse prescribers, pharmacists, and others, to see what they really think about the use of NSAIDs, and I suppose what the barriers are, what the possible enablers in the future to actually using these drugs potentially. So in terms of mixed methods, it's quite simple. It starts off with a survey, very short 5-minute survey, leads into some optional interviews, leads into some optional focus groups, and we hope to take that data and into the next step. So the step 2, addressing challenges, and this is where we hope to, I suppose, co-produce some possible solutions based on that data. And don't know, the solutions might be a trial, possibly. It might be going back to the basic science and looking at the mechanisms. It might be something completely different. It might be that actually we should just drop NSAIDs altogether and focus on other things which have a least resistance, vector sheath catheters, spinals, gabapentin, something like that. But if we do decide to take it forward, we'd then do some kind of study, stage 3, to try implement change. I think we should probably remember that EVAS guidelines at the moment, at least, do recommend the use of NSAIDs. So that's something which we need to try and remember. But I suppose to start this, we really do need your help, and as many people has helped around the globe to help us with this survey. It's very short, 5 minutes, and thank you, Blood, and the editorial team for letting me plug this. But if you guys wouldn't mind having a quick look at this survey, you can see the link just here. You can use the QR code. It's mainly free text responses. We just want to know your opinions and perspectives. So some of you might use NSAIDs and some of you may not, and all of those opinions are really important. So if you wouldn't mind spreading it around your local networks and your local colleagues, that'd be excellent as well. And hopefully we can try to take this work forward a little bit further.
Thank you for that. Well, this is the first time we've actually promoted a new study on the Journal Club, so that's exciting. And I have it on good authority that DC&R is a good journal to publish colorectal research, so keep it in mind. Now, let's move on to the next paper, please, which is, does coffee intake reduce postoperative ileus after laparoscopic elective colorectal surgery, a prospective RCT? And the presenting team is as stated. So please, if Dr. Lucias, would you start describing the paper?
Sure. Can you advance to the first background slide? All right, so relevant background information for this paper includes the fact that postoperative ileus is common. Dr. Diaz shared that too. It usually lasts 3 to 5 days, and longer durations of ileus lead to longer hospital stays, increased morbidity, and higher hospital costs. There have been several strategies to reduce the incidence of post-op ileus, and they've been implemented and studied, but in this paper, the authors chose to study whether coffee, a cheap and tasty beverage, would make a difference. And specifically, the objective of their study was to compare the time to first bowel movement after laparoscopic colorectal surgery between patients drinking coffee or tea postoperatively. Next slide, thank you. This study was a prospective randomized control study. It was conducted between 2014 and 2016 and took place at a public hospital in Switzerland. Patients were eligible if they were undergoing a laparoscopic colon or rectal resection, and some of the exclusion criteria included formation of a stoma, any additional small bowel anastomosis, if the operation was emergent, patients preoperatively taking agents influencing gut motility, and use of a post-op epidural. Patients were randomized to either a coffee or tea arm. Patients in the coffee arm received 150 milliliters of coffee 3 times a day at 8 a.m., 12 p.m., and 5 p.m. starting on post-op day 1. And in the tea arm, patients were given the same volume of caffeine-free tea at the same times. Patients in the tea arm were not allowed to drink coffee at any time. The other perioperative management of these patients was very standardized. The authors chose to study time to first bowel movement as their primary outcome, and then use of laxatives, insertion of a nasogastric tube, length of hospital stay, and complications as their secondary outcome. Next slide. So in total, 115 patients participated in the study, with 56 in the coffee arm and 59 in the tea arm. The baseline demographics between the groups are similar, and notably all patients were actually coffee drinkers at baseline. The overall complication rate was 26.1%. And in terms of the major results of this study, the time to first bowel movement was significantly shorter in the coffee arm at 65.2 hours versus 74.1 hours in the tea arm. For length of stay, the authors found no difference on intention to treat analysis, but did find a shorter length of stay in the coffee arm when comparing the groups that strictly followed the protocol. And there were no differences found in any of their other secondary outcomes. Last slide. One of the bigger limitations of this study was that there was an almost 17% protocol violation. But in summary, the authors concluded that compared to tea, early postoperative coffee intake leads to a significantly shorter time to first bowel movement, and thought that this 9-hour difference may help reduce overall length of stay. So they recommend integration of coffee as an adjunct to other strategies employed to reduce postoperative ileus.
Thank you. Thank you, Dr. Lucias.
Yeah, thank you very much for that. That's a great summary.
Thanks.
Dr. Quakey is, I'm sorry, I can't pronounce
I was trying to bail you out there by jumping in, but it's Kwache, so Kwache.
Okay. Well,
John, you're muted.
And notice I didn't help him with the name at all. I just kind of sat back and enjoyed it. So
I expected that was a little bit of a hurdle. That's why I jumped in earlier, but thank you so much.
Maybe it's the Australian accent.
And thank you so much for having us. It's definitely a privilege to be here today, spending the evening discussing these very interesting papers. And thank you, Dr. Lucius, for doing a nice job summarizing everything. So as someone who didn't start drinking coffee until I became a faculty, I think I have an issue with just the basic premise that everyone enjoys coffee and that it's something that will be widely embraced by everything. There's also, since this is 2021 and we are more aware of some of those social cultural elements, I have to also point out that coffee drinking is preferred by certain folks and not necessarily universal. So something to keep in the back of our mind as we try and discuss possible interventions that should be widely adopted. So the basic premise, I have some question with that. And also I should point out that I drink cream with coffee instead of coffee with cream. So it's mainly the cream that I want. In relation to Dr. Bogan sort of broke down his review in terms of reproducibility and then how reliable the information, the results are. When I look through this, and I might have missed it, but I don't see any information in terms of how much caffeine dosage was used in this particular study. So are we talking about a teeny little increase above what you find in tea, or are we talking about what you find in espresso? And pardon me, I really don't know my coffee at all, so I don't really know if espresso has a whopping amount of caffeine in it compared to like your regular. But what are we talking about here? How much is this dose of caffeine that you really need in order to trigger you to go to the bathroom? And then when we think about the time difference, so it's 9 hours really important, a difference. Will that make a huge difference in terms of our length of stay? Are there other things that are accounting for that difference that we might be missing? It might not really be due to when you first have your first bowel movement. Dr. Lucius pointed out some of the limitations, that there are other things that drive the post-op ileus or the nausea, vomiting, that is not all tied to when you first pass gas. And so that's something that we're also missing here. So my main issues are the premise, the baseline premise for which this is based on, how reproducible, because we don't have much detailed information about what exactly the caffeine content. And then is also are the findings really important? Is it really going to make a difference? And this is something that we need to include in our ERS protocols compared to some of the other things that we have already established. So that was very brief. And I'm going to read the chat. Oh, light rose. Okay, thank you, Dr. Regenbogen.
Thanks for that. I liked one of the things that appeals to me with this study is it's achievable in pretty much any hospital center. And so I do think that there's some novelty that the authors identified, and partly working in a smaller place at the moment in Australia, like it appeals to me that you can still, you know, run an RCT and publish it, and it is fairly novel. But maybe I thought I'd organize one where I would have Coke versus Pepsi and get it sponsored, and then with the proceeds build a big hospital. But back to some of the points about this paper. You've kind of touched on the definition of an ileus when you mentioned. Now, in the paper, they also say postoperative nausea and vomiting and time to bowel movement is kind of a surrogate to ileus. How do you define ileus in your center? Because I assume even just for coding, it's something that is important. So how do you do that?
Do you have a good answer for that, Dr. Quachi?
I was going to say, I don't know what. Oh, you know, Dr. Brand?
I don't.
What else? because I don't know what our official diagnosis or the way we identify for coding purposes are. But I think typically we look at return to bowel function. We typically expect, depending on what procedure they've had done, is within 24 to 48 hours after surgery. And if they haven't passed gas or they haven't seen, and usually we use gas more so than having a bowel movement. So if they haven't passed gas within that time frame, we typically expect them to, then we think the gut is slow to wake up. I don't know what the official definition is for coding or billing purposes.
Yeah, I don't know either. I guess I kind of look clinically and see if the patient's distended, and particularly they're hiccuping and they've got reflux, I'd probably start thinking about an ileus then. But I don't, I think gas is probably useful, but time to bowel movement is a tricky thing. Personally, I think it's hard to use. Now, in the same paper, they mentioned that if a patient doesn't have a bowel movement on day 4, they start giving paraffin oil. In your post-operative protocol, do you factor in laxatives? And if so, when, how, and why?
Yeah, I can.
Go ahead.
Oh, go ahead, Bob. I can tell you that in our center, amongst my partners, everyone differs. We definitely don't use paraffin oil. It's not something that we use at all. Most of us like things to happen naturally, and so we do push a lot of early ambulation right from post of day 0. So we have all these things that we do to try and get the gut working as quickly as possible. A few of my partners might give some laxative to stimulate stuff, but that is rarely, and that is only in unique patients. Most times it is just like waiting for things to naturally progress. Dr. Barron, you were going to add something?
I can't remember what I was going to say, but I was going to say that I don't think we use a lot of laxatives, but if you put the paraffin oil in the coffee, that might really get things going. I did want to say, I think for both the opioid reduction and the kind of the length of stay stuff, and you just said it, Dr. Quachi, was the early ambulation. We've had quite a bit of success with length of stay reduction through a push to early ambulation, which I guess most people would find that not a pain control issue, but I do think it does help. The only real thought I have of this study, which hasn't been said, is that the length of stay is quite long. And I think most of us don't really wait for a bowel movement to send somebody home. If the patient is not clinically bloated, if they're tolerating a diet, if they're passing gas, they can probably go home. So on the other hand, a hospital day reduction in the US health system would be extraordinarily valuable and worth the 150 milliliter cost of lukewarm coffee.
Thank you. That's a good point about the time to discharge. So they mentioned 6 days in the interventional group and 7 days in control. To sort of further that notion, when do you say that a study is no longer relevant to your local practice? Would there be a cutoff if you say you have an average of 3 days, this is 7? Do you kind of say, well, what am I going to do with this information?
Scott, you might have something to say, it looked like.
I said yes.
Yo.
Yeah, I mean, it's, if the outcome, this is the problem with an outcome of length of stay, is it is highly dependent on all kinds of factors that are extremely subjective, and so you really run into a problem of sort of self-fulfilling prophecies and expectations around discharge. So the question becomes, were there standardized discharge criteria, or was it subjective? Were there, to what degree was there really effective blinding between the two groups, and a variety of other things? And so time to discharge is a tough one, and for sure, 6 days versus 7 days makes in the modern era, it just makes it kind of feel like we'd have them all home before that.
My last question is in relation to the distribution of which bit of colon is resected. Now, personally, I find with my cases, patients tend to get an ileus more from a right colectomy than an anterior resection. Maybe it's my technique, maybe it's anecdotal, I don't know. But do you find a particular part of the colon, or mobilizing the mesentery affects motility more or less, or is it just in my head?
Dr. Quachi, do you have a point of view on that?
Yeah, I was actually thinking about that. I don't think I've actually paid attention to that distribution necessarily. I think about right colectomies, we generally do them laparoscopically. And for most of us, thinking about my partners, we're getting them home within that post-op day 2 on average, sometimes even earlier than that. Sometimes we send them out even when they haven't had bowel function yet. So it's very hard to then track that whole ileus, and it's hard to measure how many of those folks actually might develop something at home that we never even hear about. The folks that we hear about are the ones who get really sick and clearly have some sort of issue and need to come in. I don't know, I haven't really paid attention to that. And we do a lot of our left and also laparoscopically or robotically, which I think makes a little bit of a difference in terms of that length of stay and also that ileus sort of post-op recovery. So I don't know, I'll be interested to hear other people's views.
For all it's worth, in the intervention group, there's 10% less right colectomies than in the control group. All right, well, I'll just check if there's anything else in the we just got coffee discussion versus tea in the chat. All right, let's move on to the next, just the results of the poll. Stephen, if you can tell us those, please.
So we had a probably relatively significant portion of people that were more restrictive, which is to say they used either urine output or they were just restrictive and watched creatinine, presumably at least daily, to monitor urine output. And then there are some still people that have just scheduled 2 to 3 liters per day, and we don't have a definition for the others. I'm happy to hear any other of the others put their thoughts into the chat.
One of the other studies that we featured this month was about removal of IDCs. This is from Dr. Fleschner's group in LA, and they demonstrated there was no difference between removal in day 1 and removal day 3 from a urinary retention point of view. I do find, when people say they titrate hydration to urine output, does that mean that putting in a catheter is a must, or how do we do that? I think sometimes these things might not marry. The other study that we featured this month was about sort of intraoperative hydration, and to see if sort of relative fluid overload intraoperatively will result in an ileus. And I must say, I notice when the patient starts moving on the operating table and I look at the anesthetist, but I never look at the IV pole to see what fluids are running. In Michigan, as part of your sort of ERAS perioperative protocol, do you have a say in the IV hydration intraoperatively, or does your sort of management start when the patient is sort of in recovery and onwards?
Go ahead, Scott.
Yeah, no, we designed the protocol to be truly soup to nuts. So it really starts from the time that we book a case until the time the patient arrives at home. We consider all of that to be the perioperative period. So this required working with the anesthesiologists, and they created a separate, what they call case script. These are sort of like the kind of like step-by-step little do this, followed by this, followed by this that pops up in their computer system. They created a special one for colorectal surgery. Our battle was then because we don't work with a necessarily consistent group of the same anesthetists or anesthesiologists, making sure that they actually knew to use our case script and didn't select whatever, random general surgery case script that was written in 1974 and still involves, 17 nasogastric tubes. And so that took us a while. And for that, we looked at the first 6 months after we sort of launched our ERAS protocol, and they were using our case script less than 20% of the time, which just made me bonkers. But if they do use our case script, it holds them to about 60 cc's per kilo per hour, which is a pretty, means that if you do a random kind of laparoscopic operation, takes a couple hours, the patient will get about 1 liter of fluid.
Okay. Thank you. Certainly, it's something that we have a different system in Australia, but it's something that I've intend to kind of focus on, at least in my private practice. I haven't before. All right. Well, thanks for that. I can't see any more things in the chat, so we might move on to the next segment, which is our special guest segment. And we feature Dr. Byrne. Now, he is the Clinical Associate Professor of Surgery in the Division of Colorectal Surgery. He received his MD from the University of Illinois, Chicago, and then he did his general surgery residency in Mount Sinai School of Medicine in New York, subsequently did a colorectal fellowship at the Cleveland Clinic. Prior to his current appointment in Michigan, he was a associate professor at the University of Iowa Hospitals and served as the chief of the section of colorectal surgery there. And we're going to talk about video coaching. So thank you very much again for participating and volunteering. And if you can please tell us, what do you mean by video coaching to start with?
Yeah, thanks so much. And I do just want to thank one more time Alicia and Sarah and Scott and Gifty for helping out with the articles. So you can show the next 1 or 2 slides, I guess, go through them. I think video coaching at its most simplest is surgeons, either in pairs or as a group, reviewing video of surgeries and discussing the technique. I think that's the simplest iteration of it. This is something that really started for me when I came to Michigan. There was an article written and published in New England Journal of Medicine in 2013 by our bariatric group. And essentially, it showed a relationship with skill review of a video of a laparoscopic gastric bypass and outcomes. So, and it got a little bit of press even in the in the media. Essentially, if there was a good surgeon operating, you could kind of tell from watching the video, and that correlated with outcomes. And I think that the natural progression of that is to try to improve your technique. And this is something that Michigan has invested a lot of time in, as well as the University of Wisconsin, which we've had a lot of collaboration with. And I think the idea is to improve your technique to improve your patient outcomes. The video coaching that we do in colectomy is a R01 funded program in partnership with the MSQC, which is the Michigan Surgery Quality Collaborative, which is a statewide quality collaborative funded by Blue Cross Blue Shield. And then we have additional funding from our grant. And our form of video coaching is what we call formative feedback. And it's essentially modeled on the after action review, which is, I'm not a military person, but essentially this is something the US military has adapted significantly. And it's essentially what the movie Top Gun is about, which is the training in the desert, fighter pilots, and then reviewing the video and trying to see what you could do better. And that is the form of video coaching that we do for colectomy in the state of Michigan through the MSQC and our University of Michigan research. And the other thing about formative feedback is it's top down, bottom up. There are not better experts in the room. There are not peers who we know are better technical surgeons than others, either by video review score or by outcomes. And that is one of the revelations of the after action review in the US military was breaking the chain of command, and everyone in the room was an equal partner in the discussion of the video to find out what is the best way to do it. And so that's one of the other main principles of it.
So
we moved from in-person to Zoom. And so the second two slides there are screenshots of us on Zoom doing it. And we had done it in person for a couple of years, and we've done it in Zoom for about 18 months. And it's translated really nicely to Zoom.
Thank you. It does sound very interesting. Now, a few questions. When you have these reviews, is the person learning the one that did the operation, and therefore you're reviewing your own skills, or someone is helping review your own skills, or are you learning by seeing a dissection done by whoever? And is there a difference in educational benefits?
The best thing to do is have a surgeon, bring a video of their own that is either a challenging case or something they want to specifically work on, and offer it up to the group for review and discussion and improvement. That's the best thing to do. It's also a little bit of the Holy Grail, because that's actually a really hard thing to do. And a lot of video coaching is relationship building, trust building. I mean, how readily could someone bring a video of their surgery where they didn't do a good job to 10 surgeons, maybe 15, some of them neighboring institutions and competitors, and review the video where they weren't amazing and try to improve? So it is the best way to do it, but it's also the Holy Grail. So we do a lot of different things. We have had guest videos. We have shown videos which were probably overly easy. But there's always something to learn from sitting down with a group of peers and reviewing technique and thought process.
Thank you. And so to break it up, do you see it, if there is a hierarchy of benefit, is it for teaching trainees? Is it for maintaining skills in the kind of early attending or mid-attending phase of the career? Is it in learning new skills which have, or new techniques which have become apparent after, 10 years after fellowship, say like robotic surgery? Where do you think is most benefit of this?
I think it can be used for any one of those things. My personal and strongest interest is what I like to say, becoming better experts. So the groups of surgeons we worked with, which has been a few different cohorts, are all either fully trained general or colorectal surgeons who know how to do a laparoscopic colectomy. And so for me, the real interest has been, we're experts at this, but can we be better experts? And can that translate into improvement in the quality of the surgery for the patients? I don't know if that resonates with people, but that is my strongest interest. I think a close second is probably new technique development. Myself, like maybe some other people on this call, kind of taught themselves how to do robotic surgery sometime in the last 10 years. And I think from some studies we've done with surveys and from also just knowing people my generation, there's a better way to learn the next new thing than you know, the weekend course kind of paradigm.
I agree with you. Something I notice when I'm operating with trainees, particularly if they're more junior, is that they don't seem to see what I see in the same operative field. I guess it's got to do with, in colorectal surgery, primarily identification of surgical planes. Now, when you have the experiences of reviewing the videos, do you find that you see planes in your own dissection which you wouldn't have seen before, or is it something that that you kind of, you can see in other people, or other people can see in you, but you don't get that sort of newfound identification or newfound view if you review the case?
So I do think if you're interested in surgical coaching, but you don't have an outlet for it, you get huge gain just from reviewing your own video and watching the whole thing unedited in real time. And I think that is that's kind of everybody's first revelation when they enter into one of our coaching sessions, is when they review one of their own videos. They have so many kind of aha moments. It kind of in my preparation for these coaching sessions, I've dabbled in a little bit of research on expert learning as a field. How does someone become an expert? And as I said before, how do you become another expert? And kind of to simplify the way I understand this field of expert learning is, this concept of intuition or surgical intuition, or I kind of see the future. If the resident does this, they're going to injure the ureter before they do. That's a real thing in expert learning. And what I call it from my reading is mental models. And a lot of people use mental models, but to do different things. But when I talk about mental models and surgical technique, I'm talking about surgical intuition and seeing those planes, those steps, those snapshots kind of as they go. And that is exactly, your question is exactly what the video coaching is about. It's about getting everybody in a room looking at the same thing at the same time and discussing it to see who's seeing what and why. And you can kind of decide for yourself, or there's often a consensus in the room of like, okay, no, this was what was happening and this is what needed to happen to correct this minor, moment of being out of the plane, or we've had reviews of inadvertent injuries to bowel and things of that nature, where people see that all different. The analogy to the resident is the same. The residents just aren't really as good as the group we have together, because we're all practicing surgeons, and so they would have a lot more to learn. But what you're saying is a thing, and it's how you become an expert, is when you start to see those things intuitively.
I've been thinking of, and I wouldn't have the capacity to do this, and I don't know if anyone can, to have kind of a find your own adventure operation where you have a view, say, from a medial to lateral approach of the ileocolic pedicle, and you can point where you would cut, and then they would take you to, the next step, whether you're in the right plane or not, and then you can identify further, but you'd have to sacrifice a few people to get into the wrong planes, I guess. But now, one of the things I remember when I did my fellowship exams is in Australia, and I don't know what it is like in other countries, but it's very labor intensive, and the exams are genuinely difficult. But then you have the part of the exam when you talk to a surgeon about the operation that you would do. And I think it's quite a limitation in accreditation, in that no one sees me do an operation. I can elaborately describe how great my anastomosis is, but what does that actually mean? Do you think that this could potentially be integrated into accreditation, or where you demonstrate, you record an operation and you demonstrate it and you get graded on it, or would that sort of detract the or affect the bias of giving your work or sharing your work? Does that?
I think it's realistic. I think some studies have used accreditation. I was accredited for the ACOSOG Z6051 trial. I think it's real. I think the limitation for simulation, accreditation, intense video review, and all these things are time and money. And the real gold standard for simulation, for coaching, for video for review, for these things is at least in the US, is the US military. And pilot training and things of that nature. And the time and the expense is extraordinary. And there's not just financial expense, there's human life. When they do the Top Gun training, just like Goose in the movie, God rest his soul, people died in Top Gun. When the US military does training sessions to prepare for war, people die. And so it's extraordinary cost. And so it can be done, but it's, when we do a video session every 3 or 4 months for 2 hours, 3 hours, it's a huge expense for the surgeons who some are academic and they got so much stuff to do, like Scott, and then some people are in private practice. And so that's the limitation, I think. I think it can be done for sure, but that's the real hurdle to me.
One last question I've got. I love your cup, by the way.
Yeah.
Now, do you think that the video coaching is operation specific or component specific? Meaning, if someone isolates a pedicle very well, can they isolate any pedicle? Or someone does a transection well with a stapler, can they do another form of stapling? Like, are they better at a intracorporeal anastomosis?
I think the thing that interferes with that is the patient. Inflammation, obesity. I think we all know our limitations when are driven a lot by patient factors. But the way I do the coaching study, the parts I've designed, much to the chagrin of some of the scientific-minded people like Dr. Alicia Lucy's and Ari Cantor's. The way I approach it is more of a one-size-fits-all. I really think we can take any case anybody wants to do, we can work on it and we can try to improve. But that really murkies the water of our study, of our outcome management. But the way we started this at Michigan with the colectomy stuff was really just a quality improvement program for surgeons participating in our collaborative who wanted to try to improve. And so that kind of was the narrative where we just wanted to try to improve our technique. So whatever people wanted to bring in is what we worked on.
Well, thank you for answering all those questions and sharing it with us. I think it's very exciting, and certainly it marries the progress in technology, which is only going to grow, with the transparency of you know, and being ethically appropriate to share one's work and stand by it, whether it's good or indifferent. So I'm looking forward to seeing a lot more of this, and maybe it's also an opportunity to join into these sessions from halfway across the world, because if you're doing them on Zoom, there's no reason why that can't happen, with enough coffee, of course.
Yeah.
All right. Well, if there's no other comments from the chat, we'll probably wind it up. Again, I'm very grateful for the hosting institution. Thank you all for tuning in. Hello to anyone who might be watching it on YouTube later, and we'll be back in the end of January, and we'll put up hopefully a program for at least 6 months, or if not the year, for next year, and we'll hopefully explore some interesting topics. Thank you all.